I'm Katherine Nordal. I'm the APF Vice President. It's a pleasure to be here today to honor the current and legacy leadership of the Mount Hope Family Center. We are joined by Doctors Sheree Toth and Jennie Noll. Although Dr. Cicchetti could not participate in today's event, we recognize and celebrate his many contributions to this incredible leadership team. As a premier private grant-making foundation for psychologists, the foundation awards over $2 million every year in grants, scholarships, and awards that support psychologists and students who use psychology to create a world where people are healthy and happy and live with dignity. APF is unique in that it receives the overwhelming majority of its funding from individuals like you who are attending tonight. We cannot express enough our gratitude for your investment in APF and the important research and projects that we are able to fund on a regular basis. As we proceed through this conversation with Drs. Toth and Noll tonight, if you have any questions, please feel free to enter them in the Q&A feature that's found at the bottom of your Zoom screen. We will do our best to address all questions at the conclusion of the program. It's now my absolute pleasure to formally introduce today's guests, representing the current and legacy leadership of Mount Hope Family Center, Drs. Sheree Toth and Jennie Noll. The current and legacy leadership of Mount Hope are recognized for their immeasurable contributions to the field of psychology, not only the field, but also to the community in which they reside in Rochester. For over 50 years, Mount Hope has been an intellectual powerhouse in the area of developmental psychology. Its leaders have advanced groundbreaking theories in developmental psychopathology and led pioneering efforts in prevention of maltreatment of children, including landmark trials of child-parent psychotherapy, innovative programs to prevent child sexual abuse, and approaches that promote healing and resilience. I guess a testament to the zeitgeist of this place is they've won over $94 million in grant funding. Their research has spanned across genetics, biology, relationships, and systems, reflecting their transdisciplinary approach to advance the field, prevent abuse, and best support families and survivors. Their work has touched and transformed the lives of countless children and families. So please join me in welcoming Dr. Sheree Toth and Dr. Jennie Noll.
Thank you, Katherine.
Yeah.
It truly is an honor for our leadership team to receive this award, and I am personally just blown away to join the legacy of the other incredible visionary leaders in the field. So thank you.
So let's dive right in. The Mount Hope Family Center has an incredible history of serving the Rochester community, while also advancing the field of developmental psychology. Looking back, what was the early vision for the center, and how has it maintained this vision while expanding its impact across nearly 50 years? I believe the center was founded, in 1985?
It was actually founded in 1979, but I'll get into that a little bit because it was a very different entity at that time. Right. Jennie, if it's okay, I'll maybe please to start with.
Take it away.
So really, I think our vision at Mount Hope Family Center was to a real commitment to utilizing theoretically guided, theoretical theories to inform the development and evaluation and provision of therapy to some of the most vulnerable children and families in our community, with the overarching goal of not just sticking to the Rochester community, but reaching really the world more broadly. When Dante came to Mount Hope in 1985, we were located in a very small, somewhat dilapidated building. We had 2 social workers that were employed there, and we had a handful of preschool children. We provided parent training groups and individual therapy to some of the children. We were so short-staffed that Dante, who was never a self-described clinician, actually provided therapy to some of the children so that they could get therapy. But really our vision very early on was to transform the center into a world-class clinical and research facility to really benefit the vulnerable members of our society, and to ultimately inform social policy on behalf of children and families. We recognize the importance of translating our research into broader initiatives and to impacting social policy. We always had a commitment to a team-based approach, and we've maintained that over the years. I think the final thing that I'll say is that we have always had a commitment to respect and relationships, not only for the children and families we serve, but for all of our staff, no matter what their position is at the center, and for our communities more broadly. Jennie, with that, I'll turn it over to you to carry on.
Well, I'll just add to that, and I think, you know, of course, as per usual, Sheree's being a little modest. This amazing place where research and clinical work are truly seamlessly integrated, I think sets it apart from many other places in the country who purport either to have a strength in one or the other. And the fact that some of the premier trauma treatments have been developed here at Mount Hope Family Center with the population, right, that it really intends to serve is also unique. So the families that trusted Mount Hope Family Center in terms of the clinical services that were provided were then the same families that would stay for the research. And traditionally, those are the families that had been left out of clinical trials, that had been left out of some of the research that it was supposed to actually be leveraged for their betterment. So to be able to have that seamless integration, I think has been amazing, and it has elevated the rigor of the science in ways that Mount Hope Family Center has recognized as one of only 3 of the centers of excellence in the field of child maltreatment that have ever been awarded by the NIH. And part of that comes from, you know, things like their summer camp. That's a therapeutic summer camp for families in the community that need solutions to summer camp programming, but also have social and emotional learning needs and trauma needs, are the same families then that came into our research programs that are now being followed up for 25 and 30-year follow-ups. And so some of that really innovative work that Dante and Sheree and Jody Manley thought to integrate in those early days in the summer camp programs and so forth, now have really informed some of the benchmark bedrock, you know, science that has shaped the field. Not just the field of development and psychopathology, but how we understand the impact of stress. So stress physiology much more broadly. So just to bring it into the current vision, you know, Sheree and Dante laid those bridges and they built those relationships, not only in the community, but around the field in ways that when I came 2 years ago, I merely had to walk across. And so I can't thank them enough, and Sheree can't be a more gracious partner in handing that baton over. So that's kind of how I'll summarize how I see it.
Well, and one of the amazing things about the summer camp was Jody Manley was a graduate student, and she worked to start the summer camp as her dissertation, which, talk about ambitious. And it really, as Jennie said, has set the groundwork for decades of research where we're now following children that we saw in their early school age years into young adulthood and looking at the effects. I know we'll talk later about the embedding of stress and how that plays out, but that to me is absolutely remarkable. And really, I think one of the few research programs that has that longitudinal component.
It sounds like you all maybe were early precursors to what we have referred to maybe in the last couple of decades as integrated care, and the role for psychology in those kinds of systems. It took us a long while to figure that out, but it sounds like you all had some good ideas about that up there in Rochester. You may have sort of hit on this next one then. So Mount Hope has been recognized as an intellectual powerhouse in developmental psychopathology and maltreatment science. And so from your perspectives, and that you sort of addressed this, but maybe could go a little further into it. What has set Mount Hope apart from other researchers or other professionals in the field in shaping this field of developmental psychopathology and maltreatment science?
We really often conceptualized Mount Hope as a three-legged stool, with one leg being research, one leg being prevention and intervention, and one leg being education. And to me, that was awesome, but in some ways very challenging, because to come up with an elevator speech to define what Mount Hope does, we never fit into a single bucket. And so we were so broad reaching and spanning across so many domains that it was challenging. You know, somebody would say, so you're an educator. Well, yeah, we educate. Oh, but you do intervention. Well, yeah, we do intervention, but you know, we also do research, and the reciprocal interplay between research and clinical service provision has always been a hallmark of Mount Hope Family Center. People always used to kid me in the early days. I interviewed every single person who applied for a therapist position at Mount Hope. And the joke in the center became, if Sheree asks you what you think about research and you say you don't like it, you're not going to get a job. So I think that we have maintained that commitment, not only thinking that research can inform clinical practice, but the clinical practice we learn from what's happening in that arena, and it feeds into our approach to much of the research that we do.
Yeah, and I guess I will only add the perspective of the whole individual that exists not only in their biological systems, which I think, you know, the research that we do here and that we've partnered with other key researchers across the country to champion. And I know that because when I was at Penn State the last decade, and then Cincinnati Children's Hospital before that, and when the idea of coming to Mount Hope was put in front of me, I said, absolutely. Because I've known about Mount Hope my entire career, and Dante, Sheree, Fred Ragash, among others, Seth Pollack, you know, Patrick Davies, they shaped the way that I was thinking about my own science. And I was thinking about how to think about the individual who is placed not only in their biological systems, but in their family systems, in their communities, in their culture, right? The various levels of functioning that I think developmental psychopathology really championed. And then, you know, the discipline was born there, the flagship journal, you know, from there. So, you know, it was a no-brainer for me as a scientist to understand what was going on at Mount Hope, but then to have the privilege to come and lead it.
And Jennie, I'm glad you mentioned the Development and Psychopathology, the flagship journal, and how that really set the tone for much of the field. And the other thing I would mention is, for a decade, we held a symposium on developmental psychopathology at Rochester, and we would invite leaders from across the field. We would pick thematic topics, and we actually produced 10 volumes of that spanned all areas of development and developmental psychopathology. And that was quite the undertaking, because at any given time, we were planning the next one, we were editing the chapters that we had received, and then trying to move forward on, you know, how we were going to get the volumes published. So, but between development and psychopathology and the Rochester Symposia, I think we made major contributions to the field.
Sounds like you both are really great at multitasking and keeping a lot of plates spinning in the air at the same time. You both have been at the forefront of advancing prevention of maltreatment of children, from landmark trials of child-parent psychotherapy to multi-tiered child sexual abuse prevention programs. Dr. Noll, your recent program was shown to spare or prevent child abuse in some 110 children and save $31 million in public funds or public costs in just 3 years. So what do you think makes prevention work in real world communities? And what is it like to see your research translate into such tangible impact? It must really warm your heart, so to speak.
Yeah, I mean, I think it's a dream come true for any basic researcher like myself doing observational studies for about 3 decades to then turn the tables and say, we've been studying this phenomenon, let's see how we can stop it from happening in the first place. So then, turning to primary prevention models and a public health framework for how you want to impact population level prevention. And so I will just say, it doesn't happen overnight. You don't get invited to those tables. You have to kind of earn your way. You have to earn trust, build relationships. And so this happened at Penn State when there was a crisis. There was a scandal. Penn State, the football coach abused all those kids. There was a cover up. There was a scandal. And that meant there was an appetite. There was an appetite for change. There was an appetite that this never will happen again. And that appetite was palpable not just with families and in the immediate community, but within the policymakers in Pennsylvania who wanted to be champions to stop this. So that is something that I was able to leverage and also to work with the state policymakers to say, if you really want to stop this, you got to let us do real science. And here's what real science looks like. It looks like a controlled trial. It looks like population level impact. It looks like multi-sector work, right? It looks like using the evidence base that we have accumulated in a coordinated way, right? With the multiple sectors, children, parents, adults coming together to solve an issue. You can compare it to things like lead abatement in the 70s. How did that work? It worked because multi-sectors came together and worked together and were coordinated. So we were able to do that because the legislators understood science and we helped them understand the use of science in policymaking and they trusted us. And so we were able to do it and it worked. And then to be able to translate that, population level statistics into dollars and cents. Those are the kinds of policy relevant messaging that we need to get used to doing as scientists, because the ultimate goal of a researcher is to have your work actually change policy. And one of the ways to do that is with those policy relevant messages that work across the aisle. Some of those messages pluck heartstrings and some of those messages pluck purse strings. And so to be able to show the cost savings and the cost relevance was instrumental in getting the state of Pennsylvania to very recently pass House Bill 460, which was to make the sexual abuse prevention work in every single county in Pennsylvania. That was passed 14-12 just last month. So the idea that you come into a community, you understand the community's needs and how they want change, right? You listen to every constituent that wants change, that wants help, and you try to tailor your solutions to what the feasibility and what the appetite for change is. And that's one of the things that Mount Hope does so well, is they're embedded in the community. They listen to the community. They involve members of the community, and they're responsive to the needs of the community. And so that's something that I think taking what we learned in terms of a crisis into a community that has the appetite for change and that Mount Hope is so good at is just continues that legacy of what we were able to do in Pennsylvania.
Jennie, I'm so glad that you said that, because I wanted to add that we need to listen to the voices of the populations that we're hoping to support and help, because we could come up with the most fabulous approach to prevention, but if we haven't incorporated the actual needs that the population is telling us that they want, they're not gonna take part in it. So we could have this great prevention program out there and nobody's using it. And so really, I think over the years, I personally have become more and more in tune with needing to do focus groups before we launch even a research project, getting input from stakeholders on, this is what our recruitment brochures look like. Is this something that works for you? Is this something that resonates to you? Is this something that turns you off? And really being able to incorporate that into research designs as we move forward.
I think, having been a clinician myself before retiring and working with children and families, thinking about the importance of that advocacy. And like you were saying, that the money that was saved was, and the benefit came to a lot of systems. It came to emergency rooms that didn't have to see abused children brought in. It came to social workers that didn't have to monitor abuse in the home. It came to law enforcement that didn't have to go arrest parents. You get system-wide effects. Obviously, the best effect is for the child, where the maltreatment has been prevented. But child maltreatment and school systems, it impacts school systems when kids can come to school that aren't being abused anymore. So the effect of those sorts of things really spread, and the benefit of that spread across the community in multiple sectors, from schools to social workers to juvenile justice to the court system to the hospital systems and the doctor's offices, and the ability to get all of those advocacy, all those stakeholders together and get the policy changes you want through the legislature is really, really very powerful. And my hat is off to you.
And that also doesn't happen, magically either. Like, one of the things that we're able to develop by being centers of excellence is a model of research to policy collaboration. And it's an empirical model that we were able to develop that actually teaches researchers how to think more like policymakers and understand policy levers and ask policy relevant questions in their lab, right? Translatable questions. And then the model teaches policymakers how to actually use evidence in their evidence-informed policymakers, and then trains what we call these boundary spanners who know both policy and research, who can be those translators. So it's a model that we've used in several fields. We started in child welfare, now we use it in substance use prevention and other aspects of prevention. And it really does work. It actually results in policymakers actually utilizing more research in their traction to get policy passed. And that's really what we want at the end of the day.
Speaking of substance abuse, I was involved with a court. It was a diversion program where substance abusers could go into a program, into drug court, and get the benefits of treatment, whether it's AA or other sorts of treatment. It reduced a lot of stuff within the community, which was very helpful. And it kept folks that had legitimate mental health problems out of prisons and out of prison systems. So getting that research into policy really, really is important. Dr. Toth, your decades of work on child-parent psychotherapy has shown that strengthening the parent-child relationship can help children heal from trauma and prevent future difficulties. What do you see as the most powerful impact of this kind of work, both for families and for the broader field of developmental psychopathology?
One of our first studies actually showed that insecure, disorganized attachment relationships between a parent and child could be modified through the provision of an attachment theory informed model of intervention, namely child-parent psychotherapy. When we submitted that first article for publication, one of the reviewers wrote to us. He was very positive about it, but I kind of think I knew who it was, but he was like, how is it that what you did worked when so many others in the field have tried to do something similar and did not get the results that you all got? And I said, a number of things I think contributed to that. Number one, we did it based in homes. This was not a treatment-seeking population, which is something else really important to highlight. Because if you have a treatment-seeking population, they're typically more motivated to change. We kind of went out and beat the bushes to recruit maltreated infants and then to provide the intervention. So it was provided in homes, which decreased the possible stigma of having to go into mental health clinics. We also recognized, as I think Jennie mentioned, or Katherine, maybe you mentioned, we work with some of the most neediest populations out there. And if we couldn't help meet their basic needs, they were not going to really be all that invested in improving their parenting. So we would literally make sure that families had food, that they had clothing, that they had the supports that they needed, and building those relationships. I think that's a theme that I just will continue to reiterate, that the relationships are so important. So we had an amazing cadre of not only research assistants, but therapists who would go out week after week, have somebody peek out the window at them and not let them in the door, and they wouldn't give up on going. So the persistence and the commitment of really wanting to make an investment. And I remember one of our mothers saying that when she first entered into the intervention, she thought, this is just totally useless. These people aren't going to understand me. It's not going to be helpful at all. And at the end of her time in the intervention, she said, I really am so sad to be ending this because you all have become my family. And you have really not only helped me to become a better parent, but you have really helped me to change my life. And that's so powerful when you get those kinds of statements. You know, we also, over the years, early on, we were kind of criticized about, oh, you're just using people as guinea pigs. You're just conducting research with them. And we were always so committed to having our research assistants value the importance of making those connections. We would also try to have the same research assistant follow the families over time. So they actually also became part of the family for these people. They provided support. They were there. They were consistent. They helped as needed. And so we had parents, even, you know, we had controlled trials. So we had some people who were receiving intervention, and we had some who were just in the research component. And to the person, even those just in the research component, would talk about how important their relationship was with the research assistant and how it helped them learn things based on the things we asked them that then actually modified their approaches to parenting as well. So I always thought that was incredible.
So meeting people where they are, I think that's a really important tenet for any kind of scientific research you're doing, or certainly therapy and treatment. Much of your center's research has spanned from genetics and biology to relationships and systems. What are some important discoveries about how adversity gets under the skin and
I'm going to
shapes
let
development?
Jennie take the lead on that one. I wish Dante was here for that one, but I'm going to let Jennie take the lead, and then I want to add a little footnote.
Yeah, so I think it's important to understand that a lot of what the entire field of stress biology understands about the impact of chronic stress comes from the studies with kids who have been maltreated. And studies where we know that maltreatment has happened. So we don't have to go asking people if they were maltreated or make the study about maltreatment. We can make it about health. It removes a lot of stigma, but we have the records from Department of Human Services, so we know what has happened to them. And then to have that prospective work following people over time and monitoring various biological systems has really been some of the hallmarks of how we understand how stress impacts health and why there are such grave health disparities in people who have endured early life stressors such as maltreatment. And some of these things sort of, surprised us, like seeing how stress impacts the immune system in ways that starts to impact disease susceptibility and disease course. Understand how, epigenetic, changes or changes in gene expression because of additional methyl groups that are added, right, to genes that change the way they're expressed. This is the kind of work that would only have been possible if we were able to do these really well-controlled prospective studies, because you can't randomly assign, abuse to kids, right? But you can use these kind of designs to really understand the interplay of stress and these biological systems. And now we're understanding how this kind of stress and this stress embedding, and it's important to understand, because of our work, we've been able to follow people long enough to see it embedded. It's not an overnight thing. It's not a one stressor thing. This is stress that's acute for a long time, and then becomes embedded such that it changes your biology. So there's a of hyperactivation of the stress system, followed by long-term hypoactivation of the stress system. And that's the evidence that there's embedding, right? And that takes, in some of our studies, years to manifest. And you can't do that in one cross-section. We were starting to see, work in PTSD vets and, some impact of dysregulation of the HPA and other stress response systems. But those were, those were a lot of cross-sectional studies, all in adults. And then we started to see kind of the opposite in kids, in hyporegulation, right? And certain cross sections, when we put it all together, it made perfect sense, right? It made perfect sense. And now we're seeing how stress biology impacts at the cellular level how we age, right? So we're seeing premature epigenetic age acceleration in parts of the genome we know to be associated with premature aging. We're starting to see things like brain age, right? So looking at how fast our brains are aging because of this biologic embedding as an indication that there's been biologic embedding, finding biomarkers of even maltreatment, right? So we're now starting to understand the different aspects of the lifespan converging, coming together. We're starting to understand the various nuances of aging and accelerated aging because of the early work we did in childhood, right? So now when we got funded at NICHD, the Child Institute, now we're getting funded at the NIA, the Aging Institute, for some of the exact same work, because some of our cohorts are aging up, right? So the other thing I just want to say is, even though there's this narrative about stress gets under the skin, you hear, the body keeps the score and stuff like that. What's not told in those stories is the amazing stories of resilience and the amazing stories of hope, of how some of our interventions are starting to work on reversibility, right? And what we're learning about resilience of stress biology systems and how to put together a narrative of hope that treatments really do work on biologic embedding, right? And that we can start to look at some of our therapies as ways to reverse what damage we once thought was permanent. So I'll end with that and let Sheree add.
Well, one of the things that I wanted to highlight was the one study that Dr. Liz Handley is taking the lead on as part of our Center of Excellence. And we've been able to follow our cohort of children who were maltreated in the school age years, who are now entering early adulthood. And what is amazing is to see that individuals with histories of maltreatment are showing premature aging with respect to cognitive decline and cardiovascular illness. And distressing as that is, the hope that I take away from that is policymakers and individuals who have the capacity to provide funding. If you're just talking about psychological consequences, sometimes that's not as powerful as being able to point to the health consequences and point to the long-term dollar costs with that premature aging, really underscoring the criticality of providing that early prevention. I know that in my early years at Mount Hope, I met with insurers and tried to talk about how one of our studies on attachment showed that, how wonderful this prevention was. And they were kind of saying, well, those are long-term effects and we need to have more immediate results. But by doing this work longitudinally, we can show them those end results. And I'm very hopeful that that will make a difference in terms of being able to access resources for prevention during those early years of life.
I think you're right about that, Sheree. I know in some of the advocacy work that I've been involved in trying to convince the Congress or even insurance companies that, if you do this, there will be a dollar cost offset down the road. Well, they weren't interested in the long-term dollar cost offset. We want to know what am I going to gain right now? How are my costs going to go down right now? And so it's been, certainly with policymakers, the U.S. Congress and state houses, if you can't show how you're going to pay for that, well, you should increase this kind of mental health spending. Well, if we're going to do that, then what part of the federal budget do you think we need to take money away from? So so we can pay for that. Well, you can save a lot of money if you would do, but they just don't. They don't even, when they start figuring stuff like that into the CBO starts figuring that kind of stuff in when you go for funding, they don't offset it anywhere. It's just seen as a cost. It's not seen as something where there are going to be savings down the road, or they don't, at least they don't put that in, even though you may have actuarial information that shows what the savings are going to be down the road. So it's a real advocacy challenge. But I think you may be very right that if you can start showing definitively here, even in a 24-year-old, we're seeing evidence of cognitive decline, or we're seeing significant cardiovascular disease already. Now, what do you think that's going to cost you? And what's that going to cost the Medicaid system or the Medicare system or the current health system? And so that hats off to you guys. I think it's great. Just keep
one of the lessons is we've been functioning in the human services arena for a long time.
Yeah.
And we've been doing preventive work for human services, but now we're thinking public health.
Yeah.
So we're taking a public health perspective, and we just got, for example, in Monroe County, we just got a $1.2 million grant to take our Building Healthy Children home visiting program to true universal status from the Department of Public Health, right? So they're starting to finally listen to how prevention is going to be a public health it's a public health issue. And there's many more resources in public health than there are in human services.
Right.
The last thing I want to highlight with that is those individuals in their early adulthood who are having these signs of premature aging, we're also following their children and trying to look at the effects of that premature aging in the parents on the negative consequences for those children. So we're really dealing with a multi-generational issue that we really need to get people to pay attention to.
Right. So I was very impressed to know that you have trained more than 3,700 people. And if what Dr. Noll said was true, I guess, Dr. Toth, you interviewed all 3,700 of those.
Not all 3,700.
But anyway, you've had more than 3,700 trainees that have come through Mount Hope, and many of whom I'm sure you have sent out as good researchers they lead their own research teams and intervention programs around the country. What do you hope that the people that you have mentored carry forward from their time at the center, and how have they inspired your work in return?
What I hope that they carry forward is recognition of the importance of paying attention to what we know from our research. I have high respect for clinicians. I myself did clinical work for years, integrating it with research. So, if somebody goes through our program, our training program, and they decide they want to be a therapist and they don't want to start their own project of research, I'm totally fine with that, because my hope is, and I've witnessed this, that they do carry forward what they gained from their work at Mount Hope and the knowledge of the importance of research, the commitment to wanting to provide evidence-based treatments, which is so important. That's become a buzzword, but our interventions really are evidence-based. And so I think that I've just seen that consistently. And, everything from volunteers to undergraduate students to graduate students to postdocs have just so consistently shared what they have learned at Mount Hope, and that it has changed the course of their professional development. One of our alum, who I think might be on watching tonight, Elizabeth Light, was an undergraduate at the U of R, and she said that she volunteered there as an undergraduate. That was in the era where we didn't have any money to pay anybody to do anything, and it was okay to have volunteers at that point. And she said that it really set the course for her, knowing what she wanted to do, and that it's continued to influence her professional life. So stories like that to me are so powerful and so meaningful. And I've learned from our students, our trainees, just the criticality of passion and following your dreams. And I think that when you do that, you can only end up in a positive outcome place. Jennie, do you want to add?
Well, and so many of them have come back to the center in one way or another. I can think of people like Justin Rosati, who was an undergraduate and then did his graduate training, and now he's got his K award, and he's one of our faculty, and he's one of our critical leaders for the future. Like, it's just amazing to see that, and how Fred Ragash was so, compassionate to students, and really did that really high level mentoring that went, all the way through training, and how Dante really set the stage for how he valued watching the careers of those who went through. And some of the giants of the field came out of Mount Hope, and it's just inspiring to see that. And now we have mentoring programs even for the kids who are going through our summer camp and after school program. We now have a mentoring program for them to develop their leadership, and they are coming back to be junior counselors and getting inspired to then and think about the careers that they could access. That kind of model isn't anywhere that I know of, and we're piloting that now, and hopefully that's going to be something that we can carry into the future.
Right. So we asked this final question to all of our gold medalists. Based on your experiences and contribution to the field, how would you define impact in psychology? Impact is the focus of our awards, and the awardees are people who have made significant impact. But how would you define impact from the perspective of our field? What does that look like?
I think for me, knowing that we have made an impact from the individual person to the societal level to the policy arena. And that to me is so powerful and so meaningful. And just as you mentioned, Katherine, just the thousands of individuals that we have trained over the years and that they have gone on. One of our goals of our Center of Excellence, Transform, was really to train the next generation of individuals committed to work in the area of child abuse and neglect. And we have done that through a lot of dissemination. I think I can't say many positives of the pandemic, but I think one of them was we kind of pivoted to doing a lot of webinars and podcasts that really was ultimately reached thousands of people, that if we were doing scientific research meetings or, financial limitations with people being able to get to different things, I think we reached so many more people that it made a huge difference.
If folks wanted to know how to reach some of those resources, Sheree, do you all have a link or something that you could put?
Come to our website. Come to our website.
Yeah. So what's
come to our website.
Okay,
it's all there.
What is the website? Is there
just Google Mount Hope Family Center.
Okay.
You'll find it. It.
And Transform.
Yeah, it's there under our you'll see it. It has its own tab. So you'll see it.
Yeah.
And then I would say, Katherine, that there when we started out, when I started my career about 30 years ago, maltreatment wasn't something that people talked about, and child maltreatment wasn't its own sort of field of study. It was lumped in with other adversities, or just, not really even talked about. And now we really see whole training programs, right? Whole areas of NIH being, championed by this whole, when CDC was functioning, whole branches at CDC, interested in that prevention. And now it's a field. And then to be able to see how policy can be impacted by rigorous research, to be in the room where your policies are being voted on, and then hear policymakers actually disclose that they have had abuse and trauma, and that sexual abuse has impacted their own families, and have people starting to talk about how prolific this problem is as a public health problem, is just so powerful. To get the narrative out there where we can talk about it, we can bring it into the open, and we can talk about the problem, but also talk about solutions.
Hey, thank you both for sharing a part of your incredible careers. I'm sure we would have to go for a long time to hear all about your incredible careers, but in experiences. Is there anything we have not covered in the questions to you tonight that you would like to share or add based on the conversation we've had tonight, or like I said, things we just didn't even ask you about?
Jennie, do you want to go first on this one?
Oh, I can't really, nothing really comes to mind other than just to understand that the position of Mount Hope Family Center in the community in Greater Rochester is just an amazing thing to experience. And Rochester is a very unique place, and to come from the outside and then see it unfold with so many people you meet. Yeah, I know about that place. Yeah, I was at that place. Yeah, my parents took me to that place. Yeah, how do I get my kids to come to that place? How can I volunteer? That's just, it just gives me goosebumps to be challenged with carrying on the legacy of such an amazing place. I hope I can do it, but you know, it's just kind of a magic place.
So I would just like to share that I just have to acknowledge the incredible staff, students, faculty that we have had over the decades at Mount Hope Family Center. Without them and without the willingness of the children and families that we have seen over time to really work with us, to stay with us, we would never have accomplished what we have. And the only other thing I'd like to add quickly is a little bit of a personal note. My personal professional trajectory was very unusual. I started out wanting to be a straight clinician. I worked for 2 years in a residential treatment center, and I learned a lot from that. But my passion was really wanting to integrate research with clinical service provision. And that's why I stayed at Mount Hope. I wasn't even on a tenure track position for years, for 20 years at Mount Hope. And I didn't really care because I was there because I wanted to be there. I went to a very small liberal arts college. When I tried to apply to graduate schools, I didn't have letters from anybody famous, you know. And so I fortunately got into Case Western Reserve. It was mainly clinically oriented at that time. But even back then, I knew that I wanted to have a strong base in research. So my advisor was an experimental psychologist. I had a developmental psychologist on my committee and a clinical psychologist. So what I would want to say to any students, young professionals out there, follow your passion and know that I'll coin a term from developmental psychopathology about equifinality, that you can have different pathways that end in a similar result. I never would have thought I would be a professor at a tier 1 university. It wasn't really my goal, but it really was compatible with my passion for what I wanted to achieve.
Great, thank you. Jennie, did you have anything you wanted to add?
Just that we miss Dante and wish you were here.
Yeah. So we have a few questions from our participants. The first one says, Dr. Toth, being an advocate for the most vulnerable children and their families for decades, since the 1980s, I wonder if you have any guidance to offer to the next generation of this incredibly important work.
I think I would say listening to the voices of what's being shared with you and not trying to impose what you think the needs are or what needs to happen, but really listening and learning from the populations that you want to serve.
Jennie, did you have anything you wanted to add to that?
I think Sheree just nailed it.
Nailed it. Okay. All right. Well, here's an interesting one that maybe gets a little bit personal, so to speak. How do you stay grounded when working with people at some of the hardest times of their lives? What keeps you grounded?
For me, it's been knowing that I'm doing what I care deeply about, knowing that I can't do it alone. I think recognizing that doing this work in this area, you can't be an island unto yourself. You have to know that you're part of a broader community. I think that's been one of the amazing things at Mount Hope, where we have sustained folks for decades doing this really hard work, knowing that you can don't even knock on the door. We have an open door policy. You can just go and say, I've had a really rough day. Can I just sit and talk to you for a minute? And knowing that sometimes you're going to be the helper and sometimes you're going to be the one who needs to be helped. If you've had a particularly rough time, if there are challenges out there that you're struggling with knowing how to deal with. So just knowing that you're part of a community and that we all work together.
Yeah, and you'll know in your career who you can and can't work on a team with, and those that aren't team players and those that are in it for the glory or the fame or the money, it's okay to have them move on and to make room for those who really want to be there. And Mount Hope has amazing faculty, amazing a clinician, amazing students, and I can rely on any one of them. And they can rely on me, and we come together and work hard together, and then we take time off together. We all have really we have a lot of community stuff that we do together. We have the Mount Hope Family Center Olympics coming again this January. We have self-care that's important. We also are some of the leaders through our National Traumatic Stress Network affiliations and our SAMHSA technical assistance grants on secondary trauma care and interventions. And so we've both developed and know how to spot when there's too much and when people need a break or need to be reassigned or need to have some diversity in their caseloads or their workload. And that's an important feature of taking care of the workforce so that you can continue to have an open door policy and to serve as many families as we serve and to keep the hard work going.
And one of my goals at Mount Hope was always, given how hard the work is, to have flexibility for our staff. And if somebody was having any kind of personal challenge, my approach was, you need to take care of that because otherwise you're not going to be able to take care of anybody. But then, reciprocally, I knew if I was in a position where I really needed somebody to help me out with something, I could call somebody on a Sunday and they'd say, Sheree, what do you need? So just knowing that that support network works both ways. And I think that, we've provided a lot of clinical supervision to our staff over the years, even though they're licensed and they're senior, but just knowing how hard the work is to be able to continue to do that, I think it's what has sustained the positive cohorts that we've had over the years.
We're getting really close on time, but there was a question here to Dr. Noll. Having been central to the creation of Building Healthy Children as the first county-funded primary prevention program, I'd like to hear more about Jennie saying that DOH has funded taking BHC to universal status. Please say more about that.
Great. So Building Healthy Children program really quickly was co-created by the Department of Human Services and the United Way, 20-ish years ago. And we've chiefly been working within human services. But a call came from Department of Public Health for taking home visitation to a larger scale. And so we applied with not just, our program as is, but various levels of service intensity is built in. Not every person needs the full, dosage. Some need just the community health worker and service connection and wraparound surface health. Some need mental health services. Some need both of those things. And some people need the full-fledged home visiting from prenatal through, age 3 of the child. So we have now sort of tiered our model a little bit. It's a triple P model. It's like there's nothing, highly innovative about how we've done it. There's a lot of flavors of vanilla out there. But what we've done is it was an intervention that was tailored to the unique needs of the human service population. And then we have multiple layers underneath the service provision, and that is universal education about maternal health, infant mortality, and really educating the population, not just about what they should look for in their own pregnancies, right? In terms of that their health might need, some extra monitoring, but area providers, pediatricians, OBs, funneling women of higher need into a system whereby now we screen every single pregnant woman in the whole healthcare system, as well as anyone who is funneled into the system through the universal education. And the final level is policy and advocacy through research. So we're evaluating at every single level, including population-based statistics, with the idea that we want to change rates of maternal mortality. We want to change rates of infant fatalities. We want to lower healthcare costs. We want to lower healthcare utilization. We want more immunizations. We want more women making that 12-week postnatal visit. All of those milestones that are so important to the health of the baby, and the milestones, the developmental milestones of the first 42 days, and then the first 60 days of life, all of those milestones. So it's universal in that the number of women that we're going to be able, and families we're going to be able to connect with, but the population level statistics and evaluation that we're going to be able to do that will resonate with policymakers, so that we can work on that sustainability of these models, like Triple P, like Building Healthy Children, like all of these universal programs that haven't benefited from that level of evaluation. I hope that answered your question.
Well, thank you. And we are about out of time. And that was the final question, although we may have a few lingering questions, but that was the final one that we could address this evening. Thank you both for making time to speak with us and to speak with our participants. It's been an honor to learn more about both of you and to celebrate your commitment and your impact on the field of psychology. So congratulations again on your well-deserved gold medal award.
Thank you.
Thank you to all of you.
Can I say one more thing?
Yes.
Between Dante and I, we directed the center for almost 40 years, and I am so excited that I was able to get Jennie to join our team, and I'm very excited about her carrying on the legacy of 40
Great.
years and also building upon it. So I just had to put that out there.
For 40 more, Jennie, 40 more.
40 more. Let's do it. Thank you, Katherine.
Yeah, thank you all for being with us. And so thank you to everyone who participated this evening. I do want to tell you now about our gold medal awards. The nominations for the 2026 Gold Medal Award for Impact in Psychology are open through January the 30th. So if you know a psychologist or a group of psychologists who have made impactful, innovative, transformational contributions to the field, this is a great opportunity to honor their work. There is more information on our website about how to nominate such individuals. Make sure to follow us on social media to stay up to date with events and funding opportunities. We hope you enjoyed this dialogue as much as I have, and I have certainly learned a lot this evening, and I'm grateful to the two of you for sharing your expertise and knowledge with us. Again, thank you all for joining us, and I hope all of you have a great evening and a great rest of your week. Good night now.